Welcome to the event today. I'm Blake Hotchkiss, Clinical Education Specialist with the Association for Vascular Access. Join with me a wonderful group of presenters, and we'll be introducing them shortly. Of course, Judy Thompson, Director of Clinical Education for the Association for Vascular Access. Hey, Judy.
Hey, Blake. Thank you so much for being here.
Yeah. Well, welcome to our presentation, and this is Advancing Health Equity in Vascular Access Care. We get to our presentation. So I'd like to introduce Dr. Karen Mancera Cuevas, who's going to be the moderator for today's presentation, and we'll get things rolling.
Thank you so much, Blake. And I want to welcome today for everyone to be attending our session today. And we have a wonderful set of panelists. So I'll first start with introduction of myself and my role at the National Health Council. So I'm Dr. Karen Mancera Cuevas. I am Senior Director of Health Equity. And the National Health Council is a member-based organization where we work with many, many members throughout the United States and national affiliates, whether corporate or nonprofit or association specific, within the patient-centered space. And so a lot of the work that is within the realm of health equity that I do is to lift the health equity conversations, work with partners, members, in order to fulfill the importance of that agenda, but also to provide support to our linked association NHC members. So I want to open that today with my conversation and my introduction with the National Health Council, and very pleased to be moderating today's session. So with that, I would like to move on to working to introduce the speakers. We will have them introduce themselves, and also for them to be able to explain why they are part of the AVA Health Equity team and why it's so important for them to be presenting today's topic that's very equity specific. So I will pass that on to our panelists.
Thanks so much, Karen. Hopefully I'll get our clicker working. There we go. So good morning, good afternoon, evening, depending on where you're coming to us from. I'd like to start by thanking Karen and the National Health Council for collaborating with us on this project. And I want to thank each of you for taking your time out of your day to be here today. I'm honored to be here, and I'm humbled to work with my fellow presenters. I admire their work as well as their passion for this topic, and they're gifted in their speaking ability. As you can read from my bio, I'm a clinician. I specialize in vascular access, and for many years, I have been very passionate about this topic. Now, I've been told by friends and loved ones, I'm a little bit of a nerd or a little bit of a geek when it comes to things that I don't really know or I'm really interested in. Over the past year, I've taken a keen interest in understanding health equity, and I came in with not knowing much about it at all. But over the last year, I've learned a lot. But I am very interested in this topic, specifically how it relates to my area of expertise, which is vascular access. So I'll admit I'm quite a bit of a nerd, but I don't think I'm a geek. And I'm going to have my friend Dawn explain to you why this is. If I can get it to run.
I feel this is a nerdy crowd, I do. And by the way, I am a nerd, I am not a geek. I'm a nerd, not a geek. And what's the difference, you say, between a nerd and a geek? I actually have a Venn diagram to show you. I have lots of graphs and charts. Be prepared.
But all kidding aside, this initiative, this project, this research has opened my eyes. Each day I learn new information and leaves me scratching my head. And as you'll hear a little later, that this problem was clearly identified a long time ago. We've made far too little progress. I know it's often difficult for one person to create change, but a team, a community, a movement, if you will, we can certainly affect change. And that's why I'm so committed, so excited to work on health equity and in vascular access. But now I'd like to hand the mic over to my friend, my colleague, Dr. Stephanie Pitts.
Judy, thank you. And Karen and the National Health Council, thank you so much for the opportunity to be here today. As a pediatric nurse for 25 years, gaining IV access in babies and children can be very difficult. I always knew that when I was trying to get IV access on my darker skinned babies, that it was going to be much more difficult. I never really spoke of this until last year. We conducted a review of the literature, and over 20 years of analysis, we only identified 4 relevant articles. I knew we had a really huge problem. Not only was this a clinical problem, but no one was speaking of it or researching it. And if we didn't begin to, it would continue to go silent. Last year at the National AVA Scientific Meeting, we had to address health inequities. The research that is underway today, that you'll hear about today, is because a group of researchers believed in the call to action and are working relentlessly to bring awareness and correction to the problem. My name is Stephanie Pitts. I'm a Senior Director of the Healthcare Strategy and Innovation Team at B. Braun. Thank you, Judy.
Thank you. And the clicker has a little lag, but I'm working on it. There we go. And Dr. Katie Boston-Leary.
Thank you, Judy. And thank you, Stephanie, as well, and Blake. And I'm really honored to be here. It is really, truly a highlight of my, I'll say of my year to be a part of this work. And I know we've been working at this for a few months now. So we're just so excited to be here finally to talk to you about this work and what we're trying to do here to disrupt how care is delivered, particularly as it relates to, as Stephanie mentioned, what happens with darker skinned patients compared to lighter skinned patients. And the reason this is important to me is because I can certainly relate, and I have experiences of my own as a patient, because as much as we're all deliverers of care, we're all consumers as well. And not only can we speak to our own personal experiences, but we can also speak to the experiences of our loved ones. And I know that whenever I present as a patient and I need IV care or phlebotomy care, I get comments that I would find concerning, but I would not feel that I'm in a position to do anything about it. Comments like, you didn't bring your veins today, what's wrong with you, a slapping of my arm, the delays that I get with getting someone that could provide the care that I needed. So this hits home for me on a personal level, and it certainly does on a professional level. On a professional level, I am a nurse. I've been a nurse for 30 years. After a number of stints in nursing leadership in the practice setting, I've now, over the last 3 years, have worked for the American Nurses Association. And that work that I'm doing there is really focused heavily as a director of nursing programs on nursing practice and work environment issues. Within that, of course, we, as you would expect with this topic, we're dealing with racism in nursing as an issue, which is so hard for some of our nurses and for the public to stomach, because there's a belief that, which we are, nurses are angels, but we're human too, and we're part of society. And I say in some of my presentations around this topic that we're not saints when we get pinned as nurses. And some of our biases do trickle into our work. So part of the work that we do at the American Nurses Association is that we've set up with other associations a commission to address racism in nursing. And with that work came also a cousin to that, a reckoning statement that we had to do for ANA to apologize for what role it has played to uphold racism, which is in our history. So in dealing with that work, of course, we do have, as you would expect, because of what's happening out there in society, that, why are we doing this and why are we bringing politics into healthcare? Well, it's just not, hopefully it's not a surprise to you that this does trickle in. And we all, even though we all don't have firsthand experiences, it is very real in empirical data. So I'm excited to be a part of this work. I'm excited to work with this amazing group of researchers, and I'm excited for what we'll all do today and learn today as it relates to how colorism does filter into vascular access care. So with that, I'll turn it over to my colleague, Swapna Kakani.
Hi, everyone, and thank you for having us as a team of researchers, and thank you, Karen, for inviting us, and thank you to the National Health Council for hosting, and thank you to Blake, our consistent tech guy, who is always there and going above and beyond. So my name is Swapna Kekani, and I'm a healthcare advocate. I'm Indian American. My parents immigrated from India. They were born and raised in India and immigrated from India in the 1970s to the great state of Alabama. And I was born and raised here in the US in Alabama. And if being Indian American in Alabama wasn't rare enough, I was also born with a rare disease in the late 1980s. And in my last 33 years, I've experienced a lot of different aspects of healthcare at a lot of different access points, and have really hit rock bottom, and have learned and have really, it has been necessary to become an informed advocate for survival. And in that, I've decided to use my experiences as a way to inform clinicians, but also empower my own peers for the purpose of changing healthcare and really changing how we deliver healthcare day in and day out. And a lot of my journey really involves vascular access. I like to say my vascular access game is pretty strong. I'll go in more detail of what that really means and how it has impacted a lot of my experiences. But the main thing I want to get across here is we'll talk about the details of this survey and this work, but this is the first time in my 33 years, and I think in others who are talking today, their careers, that we're actually asking what it is like to be a patient to receive peripheral IV insertion. And what does that mean in the short term and in the long term? So I've learned a lot as well in the last 7 to 8 months, and am really passionate about where this movement that we're starting and the findings that this work may bring to the healthcare landscape and the change it will bring. Thank you.
Thank you, Swapna. So we'd like to start with a land acknowledgement, and virtual events such as this make land acknowledgements a little bit more difficult because we are all over the country, which covers multiple divisions, lands, and tribes. My family spans 4 generations of native-born San Diegans. So I recognize this land I speak from as Kumeyaay. I acknowledge that I'm speaking to you on traditional territory of the Kumeyaay tribe and people. So I just wanted to make that acknowledgement, and others across the country, I'm sure we have many, many others. So let's get on to the meat of this a little bit. So today, Steph and I will talk to you about practice challenges with peripheral intravenous catheters, which we will also refer to as PIVs, PIVCs, IVs, access or vascular access, or maybe something else throughout this talk, but all of it relates to a PIV. You'll hear from Swapna as she describes her patient perspective of vascular access inequities through the lens of a patient. Katie's going to help you understand colorism of care and help you make connections to the healthcare world. And then as a team, we're going to describe the research we've been working on for it feels like a few years, but it hasn't been. And then we're going to do our best to convince you to help us get the word out. So I realize many of you already know this, but let's level this playing field a little bit on what is a PIV. Our colleagues at the Infusion Nurses Society define this for us. PIVs are inserted into a peripheral vein of extremities, and almost everyone has had one or has a loved one that's had one, and that is the big part of our study, and it is the most common invasive procedure in healthcare. So it is something that we can get a lot of data around. And with that, I think we're going to move on to Stephanie Pitts.
Thanks, Judy. Just really quick to kind of center some of the framework that healthcare organizations use around healthcare improvement. Back in 2007, the IHI shared the triple aim. So the triple aim really made a lot of sense. If we can improve patient experience, patient outcomes, we can lower the overall cost of healthcare. And in 2014, they advanced the triple aim to the quadruple aim, really thinking about if we're going to do all of these things for patients, we also have to think about those that are caring for patients. So they added the quadruple aim, including the well-being of our healthcare providers. And in 2021, the triple aim, quadruple aim, advanced to the quintuple aim, adding in health equity. This not only talks about equity within healthcare, but also access to care. So I think it's a great correlation of the advancement of this framework into the work that we're also doing here with the research we'll share in just a few minutes. Thank you, Judy.
Judy, you're on mute.
See, that's why I don't go on mute. Golly, I'm sorry. Okay, so Blake's going to load our question up for us. Thank you, Swapna. So we'd love for you to participate. If you were going to a hairdresser and you knew that there was better than a 50% chance that while they're in hairdressing school, they were never taught to do the cut that you were requesting, what would you do? And we're going to make these correlations later.
Let's take a look. You could say, yes, she likely learned on the job. Unsure. Everyone has to learn, of course, and not a chance. So our options. Give you guys a little bit more time to answer.
Some of these polling questions I made up should make some correlations a little later.
All right. Let's take a look at the results. Here you go. 67% said not a chance. 28 said, well, you know, everyone's got to learn, right? And 6% said, yes, she likely learned on the job.
Perfect. Thank you guys for playing with us. All right. Hopefully those connections will be made pretty shortly. And we are going to turn this over to Dr. Pitts.
Thank you. So Judy, thanks for doing a great job of giving the general definition of a PIVC. But I'd like to share with the audience today some startling statistics. So first of all, when you walk into a hospital today, it is very likely that you will get a peripheral IV. It's estimated that 90% of hospitalized patients need an IV access at some point during their hospitalization. What's really interesting, however, is that less than 57% of nursing students actually receive IV instruction. So think about that. That nurse that's going to place your IV that most patients get may not have been trained. And I guess that might not surprise you that the majority in the literature, up to 69% of IVs fail before the completion of their needed treatment. And as you can imagine, all of this combined with the complications associated with peripheral IVs can be incredibly costly to healthcare organizations. It is estimated that it can cost an average 250-bed hospital up to $121,000 a year just to cover the cost of IV complications. So it shouldn't surprise you that in 2021, ECRI included peripheral vascular harm to the top 10 patient safety list for the year. They did this for a couple of key reasons. One, they identified that statistic that up to 69% of IVs are unfortunately removed because they fail or there's an infection, and this happens before treatment is actually completed. So the patient still needs access, but the IV they had failed. They also identified in their database that there were a lot of infections directly associated with peripheral IVs. And on top of that, patients are often stuck too many times. This is a quote directly from ECRI that a patient was stuck 7 or 8 times before the IV was properly inserted. Unfortunately, all of these statistics tend to be acceptable in healthcare. ECRI's placement of peripheral vascular harm on the top 10 list basically said it's no longer acceptable. So let's do a little bit of a back step into time. This timeline, I'm going to take you back to 1998. This was the year that I graduated from nursing school, so I wanted to see what was really happening with IV insertion at that time. A great article was published, and it identified that the average attempt to place an IV was about 2.1. They also identified that some patients were requiring 1 to 14 attempts, and over 27% required 3 or more attempts. And in 2012, almost 1,400 patients, there were almost 1,400 attempts in over 500 patients with an average of 2.56 attempts. So imagine you're going into a hospital, you're expecting to get an IV, and almost every time it's taking at least 2 attempts. And imagine if you were one of those patients who had up to 9 attempts. That was in 2012. Let's fast forward to 2017. There was actually a publication that identified that the average attempt was 5.5 times per IV insertion. And let me take you to 2020, where it was 2.25 attempts. Now, when I go to the grocery store and there's the BOGO right when you walk in, I'm all about it. But when it comes to peripheral IV access, it's really not acceptable.
Okay, another poll question. So this is another crazy one because we're talking about health equity, but I used to buy this one bag of lettuce. You know, I think we all buy bag lettuce at some point, and I bought it for years. And then all of a sudden I'd get a bag and it would go bad far before the expiration date. So the first couple I just threw away thinking I probably didn't put it in the fridge quick enough or whatever the case may be. But this trend continued. So over time, I finally took it back to the store. And when I took it back, the clerk told me, we've been getting a lot of these back. And it seems like these are going bad well before their expiration date. So if that were what you were experiencing, what would you do with that salad again? Would you buy it again? Maybe if you're going to eat it same day, or not a chance.
Let's see what the audience has to say. Very creative polls, Judy.
Thank you.
Nice analogies. Yeah.
I try.
Right, well, let's give you guys a couple more seconds. Looks
And
like
by the way,
almost
this is not the
everyone's
salad
answered.
that went bad. This is a depiction.
Awesome. Let's take a look at the results. Okay. So 64% said no, not a chance. 36 said maybe. I mean, might as well eat it today. And then 0 said yes, I'd continue to buy.
Put a pin in that. Thanks so much for playing with us.
So back to peripheral IV catheters, and maybe you'll see the tie-in as we continue to talk here. In a really large study looking at peripheral IVs during hospitalization, it was identified that 54% of patients had between 2 and 4 IVs. And believe it or not, there was even a small percentage that had more than 10 IVs. But on average, 1 in 5 adults required more than 5 peripheral IVs per admission. I want you to think about just for a minute what you just learned. If they had more than 5, and we know based on the history, the number of attempts it actually takes, how many times were these patients actually stuck during their hospitalization? So we actually surveyed a group of nursing leaders. These were chief nursing officers, nursing directors, high-level nurses within healthcare organizations. And we asked them if they collected data on the proportion of IV insertions achieved on first stick success. And 79% reported that they were not collecting the data or they were not sure of the answer. So how has this actually impacted the patient's experience in short and long-term patients in the United States and Canada across healthcare organizations? I can provide for you a lot of different statistics, but I think it's best to hear from a patient herself. Swapna, I'm going to turn it over to you.
Thank you, Stephanie. So as I said in my introduction, my vascular access game is strong, unfortunately. And so growing up, my journey starts a long time ago, and I was born with a GI rare disease called short bowel syndrome. And so I was not born with all of my gut, and what remained was functionally and anatomically not adequate. And I lived on nutrition from a permanent IV in my chest for almost my entire life. And with that IV, that can, because it's a foreign medical device, it can often get infected. And for those reasons, I, on average, was hospitalized at least once a year since I was born, oftentimes more than that. 1 year was 5 times in 5 months. And then over the course of time, unfortunately, due to complications and lack of options, I received a small intestine organ transplant 9 years ago. And in these experiences, and in hospital settings in Alabama and all over the country, I've been to 10 hospitals over the last 3 decades. Due to various reasons, I've had to have numerous peripheral IV catheters inserted. And those reasons could be for IV fluids, those reasons could be for antibiotics, for blood infusion, and anesthesia, or just to list some. When I was a child, I went to the same children's hospital, and I didn't know any stats that Stephanie just shared with you. Why would I? And I didn't know any data on PIVC insertion, didn't know how nurses were trained, if they were, and how long they were. I really assumed many were getting the adequate training. And I definitely did not know that I may actually be called a diva outside of my home. I was definitely I am the princess, I'm the baby of the family. And I never thought about colorism in the setting of healthcare. It is a deep-rooted thought in our home and in our culture. I was always told not to go outside because you'll get dark, and this concept of lighter skin or white is better has been taught and instrumental really in my mother's life, in my grandmother's life, and has been brought into the culture of how I was raised, even in Alabama. But what I did know, and what I really harped on and depended on, was Angela. And Angela was, our Angie for short, was literally my nurse, or my angel on earth. And as Katie described, nurses are adequately described as angels. And every time I was in the hospital, I was told, we will call Angie. Let's just hope she's on call. Let's call the IV team. Let's call Angie. And so Angie was the go-to nurse on the IV team at the Children's Hospital that always came to see me. And I would get excited to see her because I knew that I wouldn't have to go through the burden of multiple sticks, or I thought. But I also learned we would have this dialogue between each other, and I learned how to adapt for her success. So I always wanted to take a shower before she would start an insertion because I just knew I would never be able to kind of clean myself or enjoy a shower the same way once you have a PIV, wherever she was going to put it. And I was going to hope that it's going to last for a while, you hope. And I would know to say, hey, I'm not going to make sure to get cold. I'm not going to constrict those veins. Do you have your hand warmers ready? And we'd have this really high level clinical conversation, and I was only 8. And then I have these distinct memories and ingrained that I always had to go to the procedure room to get an IV placed because the lighting was better, or the bed was more adept and appropriate for IV insertion. I truly, as a kid, adapted for and knew how to respond to clinicians for clinical success, be it really anything, but in this case for PIVC insertion, because I wanted to have a nurse that could be labeled as one stick wonder. I did not want to go through this one more time. How does this impact in the long run? Well, as I have become an adult and learned, unfortunately, too much about healthcare, is that I really cannot unsee what I have seen. And because I have the chronic diseases that I do have and the medical comorbidities that I do have, one stick wonder has become two sticks wonder. Can that nurse or tech put in this IV in 2 tries? Let's hope to God. Again, it's just crossing our fingers. And then it becomes that goalpost changes. And I debate with myself during the insertion, what is that goalpost? Is it worth changing that goalpost? Should we change it to 3 sticks and that's it? What is my limit? One time I did 7 sticks. And I question, is it really worth getting that other stick? Is this the burden of living longer? And then there are constant and consistent inconsistencies of how many times or attempts, depending on healthcare setting, depending on person inserting. And I've learned to become that perseverant patient and not ever complain, and always thought, oh, it's not that bad. The pain's not that bad. It's just an IV. Because you're always there maybe for something else, something more serious, a surgery, bacterial infection, something else. And we never really I have not been validated that it's okay to have pain with this. This is frustrating. This sucks to have an IV placed on your body for a long term. And then I would receive comments like, I know what I'm doing. I've done this for a long time. I don't need someone else to come and try. I can get it on 1 stick, and then 2 sticks, 3 sticks. Then they escalate care. It's a form of medical gaslighting after I have used advocacy from the experiences of the past. So because I cannot unsee what I have seen, we have changed how we approach healthcare and when it comes to PIV insertion. And some of the things that we've put in place, but it's all patient and family driven, is we have a go-to nurse in this entire city. Only 1 nurse can attempt in the home setting, and she knows my limits. And if that doesn't work, we have an immediate protocol with interventional radiology or anesthesia, who are known to be clinicians in the vascular access space that have more tools to dispense. But this was something that we had to bring to the table and ask for it. And then there's a different strategy, different language I use depending on where I am. And I've learned to say no truly means no. That goalpost is not going to change. And I have asked and ensured that documentation of previous attempts or needs of tools is documented in summaries that all clinicians can see. So this is my experience as it has been for just the PIV insertion side of this medical journey. But what does this mean? For my peers? I'm one person with one story. And when we talk about short bowel syndrome, we always say, if you've heard one story with short bowel syndrome, you've heard one story with short bowel syndrome. What does this mean for my peers with similar and or different chronic diseases, comorbidities, or even an acute setting of need for access? Many of us have gone through the journey of pregnancy and have needed an IV for anesthesia or a surgery or whatever it may be. What is the long-term impact for all of us? And with that, give it to Katie. Or no, I'll give it to Judy.
Okay, we have a couple poll questions for you, and then we'll get right back to it. And these are a little bit more straightforward. Do you know what the term colorism of care means?
I love how responsive our audience is today.
Me too.
Thank you guys for answering the questions we have.
Safe space here. In full disclosure, I didn't know what it meant a few months ago. So we're here to learn.
All right, let's take a look at the results. Thank you so much. There you go. So it's almost an even split amongst all of them, but leaning towards, yes, I'm familiar with the term and could explain it to others, leading, and no, this is a new concept, trailing.
Perfect. Thank you.
Yeah.
I think we have one more. Perfect. And how comfortable are you talking about racism and discrimination? This was a topic that our research team worked through for a long time. We had weeks of conversation talking about how we describe different races. And this was quite the topic of discussion for our team. And I think,
Fantastic.
oh, it is single choice. Okay.
All right, a couple more seconds here, 2, 1, and here we go. All right, so many people say that they can talk about it, about 45%, about 30% said I'm very comfortable, which is great to see. And then 20% I'm hesitant. I think many of us struggled as we address these issues in our research too. So, and I'm worried I'll say the wrong thing or offend. And I think that is something there as well. So thank you guys for your responses.
Absolutely. And with that, Dr. Katie Boston-Larry.
Thank you, Judy. And Wapna, thanks for setting the stage for this discussion. So for those of you that are not familiar with colorism, there's a definition on your screen. And for those of you that knew of this concept, please put in the chat what your understanding was, if it's a little different from this or not. But colorism is a skin tone discrimination, usually against those with, usually those with lighter skin tones are treated better compared to people with darker skin tones. There is a sentiment in this of anti-Blackness. And one important thing to note about colorism and anti-Blackness is that this is not purely a Black and white issue. As a matter of fact, colorism is very much an issue within minoritized and ethnic and minority communities. It dates back to, it's rooted in colonialism, and I'll talk about that later, but it goes back to the days of slavery, you know, when slave masters would have sex or rape, because not even have sex, because they were raping female slaves. And those slaves would produce children that were lighter skinned. The premise back then was that lighter skinned slaves were in the house doing chores in the house, and the darker skinned slaves were in the field. And some of that continues today. I heard a talk recently about some of the, you talk about even though slavery has ended, one of the things that continues to impact us as a society, because racism is a social construct, is this whole aspect of how we treat one another because of what happened back then to this day. So you do have you know, at one level where people treat people differently because they look a little different than them and they have a different race. But underneath that, if you pull back another layer, there is also a piece of anti-Blackness, very much a case also with indigenous populations in other parts of the world. You know that this is an issue in Australia. It's an issue in Canada as well. And it definitely does show up in healthcare. And it's important to say that because there's a belief that, as I mentioned earlier, we should not talk about these issues in healthcare. We should not talk about racism and discrimination in healthcare because it's not an issue there. And there's so much evidence that shows otherwise, not only with the people that deliver care. And we have a lot of data that we've collected on how nurses of color are treated differently compared to white nurses. And the profession is not as diverse as it should be. But we also know that there are people that believe that talking about this is politics, injecting politics into healthcare, and we're engaging in wokeism, and that is not the case. And if you don't take anything away from this discussion today, from my talk is, and this is something we hear a lot when we talk about these issues, we hear nurses say, you know, when I take care of patients, I don't see color, and we're saying that you should. Saying that you don't see color is the equivalent of saying that you have a Black friend when they ask you about how you feel about racism. So don't say that, number one. And number two, really understand all these different aspects of racism and discrimination and how it shows up. Because, you know, when you look at racism in that definition, it is discrimination directed at people because of their race and ethnicity and where they're from. And it does happen at the individual, institutional, and structural level. But we do know, and there's a lot of evidence, particularly in maternal infant child health. And Swapna talked about having a baby and getting IV care. We do see where anti-Blackness and colorism and how that shows up in how care is delivered. What you see on here is a paper bag. And another aspect of determining whether you pass the test of being accepted or not, back in the slavery days, there was a paper bag test that was being done to see how people's skin tone match up against a paper bag. And if you were darker than the paper bag, you were seen as someone that could not be accepted compared to those who would be lighter or at the of the color of the paper bag. So again, that's something you could Google, is very real. And it was also used in a lot of Black communities as well in terms of how they treated one another, because it does take root in a number of different places. Racism and discrimination shows up anywhere as long as it's given energy, time, and space. So it's important to understand that. This is also an image from those times, and this goes back to when I know some of you are probably aware of the Henrietta Lack story, and you're probably aware of some of what happened and was shared that came out when we were dealing with the statue issue and statues that were erected around different key places around the country, and they were there. And some of us took pictures in front of those statues, not even knowing what they meant. And Dr. Marion Sims, if you are someone that has any experience in the gynecological space, was considered to be the father of gynecology. And he, in his time, as part of his experimentation, did a lot of experimentation without anesthesia on Black women, particularly slaves. So it continued to push this ideology that the darker you are, the less pain you feel and the more tolerant you are of pain. And that also is showing up in a number of places. And Swapna had sickle cell and kidney disease in the middle of her, in terms of disease process that patients do have to deal with. And on the comorbidity side, these are folks that have not continue to not receive the care that they deserve because of the color of their skin, because it's not just about how the color of their skin when they are born, but sometimes disease processes also cause your skin color to darken, like kidney disease and like sickle cell. So that further adds to the situation where there's a belief that there's a toughness to the skin, which is why you don't feel pain. And that does translate to IV care, where patients of color are stuck over and over and over again, because there's a belief that, you know, you're good. You probably don't feel this as much as people with lighter skin. So we continue to see that show up. And there's also an indication, and again, I keep going back to the maternal infant child space, because that's where we have the poorest outcomes as a developed nation. We continue to see stories of patients in that space where they're undergoing C-sections and vaginal deliveries and not getting the proper anesthesia. And it really ties back to this belief that They're very, darker skinned bodies are more tolerant of pain. Forgive me, there's a delay with the slides. And part of why we're still here is because we teach this in our schools. There's this whole thing that we did for years about cultural competency that we need to put down, because it's no longer about cultural competency. It is about cultural humility that we need to have. And we also need to look at some of what's being put out there in terms of how people respond to pain that are not necessarily true. So part of our activism on this, for us to disrupt what is for us to look at all of these things and all these structures that are in place that continues to drive a lot of the thinking that we used to have or was believed about different groups of people that are not necessarily true. Because one of the things that we need to not do any longer is to treat certain groups of people as a monolith, right? And broad brush how people respond to certain things. So that's why I have this as something that I needed you to see, because part of the reason why we're still here is because of these structural things that need to be changed and systemic problems where it does give the wrong impression about how people respond to pain, among other things. This is a story about a nurse who was fired because she was concerned about Black patients in terms of how they're treated. And this was definitely in the OB space, obstetrics, where a friend of hers went to her hospital and was going to get a C-section, and her epidural wasn't working. And this nurse was voicing to her colleagues that her epidural's not working. We cannot cut on this woman until we figure this out. And unfortunately, fortunately in this case, they listened to her, but she had to throw her body against this patient for everything to stop, because they were going to keep going. And then after that event happened and she dealt with that, there was another patient a few months later that had the same issue. And she felt that she had to intervene again, but it was causing so much emotional trauma for her. She took some time off because it was affecting her emotionally. And while she was out on medical leave and she had exhausted her FMLA, she was fired. So while she was which was a very unfortunate outcome. The positive outcome in all of this is that she sued the institution and she won. And now she's an activist in this space. But it's important to also understand that even though you do have people that speak up and try to intervene, it is exhausting, because it's not just one, it's not just two, it's a never-ending stream of inequities that happen underneath the roof of where we're supposed to care for patients and give them the utmost. And I'm sure in the minds of those that were caring for these patients, they thought that they were, but we have to be open to listen, not only to patients, but to people that look like them and providers that look like them that could also relate and understand their needs. So good story here is that she won her lawsuit and she's now an activist, and she does advocate for Black women full time as it relates to equitable OB care. So all that I've shared with you so far, you have to wonder, okay, where do we start and how do we get past all these ideologies that impacts how we care about others? And I love this quote by the late Archbishop Desmond Tutu about how with everything that we're dealing with, we have to get to a point where we're not just dealing with things on the bad end and try to fix them after we have a bad outcome, but we need to get to the root. So his quote is really about, let's stop pulling people out of the river when they fall in and go up to the top of the river to find out why they're falling in the first place. My last slide is really about the drivers of why we're still here, how power manifests in the world in terms of all the isms that exist, but what we're striving towards with this work and this research and these conversations that we're having right now. The drivers of where we are today is really rooted in colonialism, as I mentioned earlier. There's also patriarchy in healthcare, where most of the people that drive healthcare at the top in terms of leadership are white and male, even though healthcare is predominantly female. And then you have more diversity in terms of people that seek care overall. With that, there's a supremacy mindset as well that feeds into the patriarchy. And there's also an air and a feeling of superiority, which helps support the feeling of there being a dominance, right? You know, when there's an outnumbering, there is a heed to understand that there is a dominant culture that's in control, that has all the power. And power shows up in the world with all the isms that we see: racism, sexism, elitism. We can expand on this list, right? Because there's so much that we have to contend with, especially right now with all that we're dealing with in the world and in society, where what we thought we had dealt with and fixed and move on from, we're revisiting again. Things that we thought we had fixed and addressed in the 60s with the civil rights era, we're back here again. So these are all the things that impact the power dynamics that's still pulling people of color down, where they're not having a voice and they're not getting the care that they deserve. But what we ascribe to do, and really how we can shift things, is to really think about how we can do these types of things, have these type of discussions, do this type of research around how, with this work, we're hopefully going to get to a world that values diversity, where people can hold multiple views, that it is fair, is equitable, and is just, where we welcome fluidity, pluralism, and everyone living dynamically. We talk about human flourishing. We talk about self-actualization. That's a shiny tower on the hill that we want for everyone. So when we finish this work, we hope that this will be the start of a number of other things that we'll do that will be done to upend power that impacts how care is delivered around the country and around the world. So with that, I'll turn it over to Stephanie.
Thank you, Katie. I'd like to share a couple of real world and really tie it even back to vascular access.
I read a story that haunted me, the story of the Fowler family.
When Mr. Fowler became ill,
3 different hospitals turned him away. He went home, sat in his recliner, and died.
and I wondered,
How many other Gary Fowlers are there out there?
Rolando Aravena,
James Glenn, Eddie Jermaine Sr., Monica Willett Simmons. She said, let me go to the hospital and I'll be right back.
He goes, I'll see you, baby boy. I love you too.
And
What if I told you the biggest indicator of how long you're going to live is your zip code?
COVID-19 divided the world into people who could protect themselves and people who could not. That was not just true across geopolitical borders, it was true within neighborhood blocks.
immediately it becomes clear to people who understand health disparities that Black people, Latinos, Native Americans, they're going to be in for a rough ride.
This is malignant neglect.
We need to stand up and we need to do something about it.
Massive progress is possible.
We need to change an entire system.
doing no harm is not enough. You have to act.
It's just whether or not we have the guts to fix it.
This is something we start now.
If you haven't had the chance to see that documentary, I would highly recommend it. I'd like to share just a few additional real-world examples that we see and many of you can relate to, not only in healthcare in general, but also specific to vascular access. There was a study recently published out of the MGH Institute of Health Professions that analyzed nursing textbooks. And we do not do a very good job of showing the difference of very simple things like a bruise in white patients, brown patients, Black patients. Imagine the disparity in IV education, a tegaderm on white skin versus a tegaderm on dark skin, and what an IV looks like in light colored skin versus dark skin that may have a complication. It's all lacking in our education resources today. Johnson & Johnson in 1912 invented the Band-Aid. The Band-Aid originally was this flush pink Band-Aid, and there were actually cartoons made with that flush pink Band-Aid on our Black and brown people. And they were almost saying like, hey, what about us, right? And Johnson & Johnson did a beautiful job a few years back creating an array of colors so that Band-Aids represent the people that they serve. And they recognize this doesn't solve health inequities, but it's a start. Katie touched on it briefly. There is a huge disparity in maternal and infant mortality. Our moms and babies of Black descent are dying at a much greater rate than those of our white moms and babies. Many healthcare organizations are working to address this, but here we are in the United States, a very advanced country, especially advanced in our healthcare system, and we are not immune to this problem at all. Swapna talked about being a diva at home. We have difficult IV access in patients, and we call them divas. And a study out of MGH identified that diva patients were often Black patients, and it resulted in more sticks, delays in diagnosis, delay in treatment, and more time in hospital beds. This isn't immune to adults. Our pediatric patients that identify as Black and have English as a second language suffer more central line associated bloodstream infections. They identify this as unconscious bias from the healthcare team serving them. Even in how we train, if you notice here, the clinician is accessing a very white flesh skin colored simulation device. We even train on white simulators. I also couldn't help but notice as I was putting the slide together that the gloves were white. I've actually not ever seen dark or brown skinned gloves. With that, Judy, I'm going to turn it over to you to share a little bit more about the research and the call to action.
Thanks so much, Steph. Now, I want to start with Mr. Dubois. In 1899, he published a book, and many of the issues he wrote about are still present today. So fast forward 125 years, and we see a tremendous amount of focus bestowed on the issue of health equity still, but 125 years. Now, the author used a term called peculiar indifference, and it really spoke to me, especially when talking about our last learning objective, the research and perceptions of patients and healthcare providers related to PIVs and health equity. Knowing that we described earlier regarding failure rates, average sticks, success, complications, our lack of improvement tell us that we are indeed indifferent. We've known about these problems for years, decades even, but we haven't looked at the differences between people of lighter and darker skin tones. We just continue to do what we've always done, is poke one more time, as Swapna so eloquently put. So I'm very excited to talk to you about the research we're doing. If I can switch our screen. And what we're trying to do is understand the experiences of patients that have had an IV and healthcare providers that insert them. We hope to determine if skin tone, race, and other health variables impact those experiences from this data and make suggestions for some meaningful change. Our team has created a mixed method cross-sectional study using online surveys. In one survey, we're asking patients, and very soon, we are going to be launching our one for clinicians. So we're very excited about this. If you live in the United States or Canada, have had an IV placed, your loved ones has had an IV placed, please do the patient survey and share it. And if you haven't, please share it anyways. And we will be launching the clinician survey next week. And we want to know what your experience is starting IVs with these same similar themes with it. I want to talk to you really quick about our team. Teamwork truly does make the dream work, and we definitely have a fabulous team. You've met 4 of us today, and we have 11 total on the, actually met 5. Blake is on our team as well, and we have an amazing team. We are clinicians, leaders, educators, researchers, patients, and all of us, I'd like to say, are all advocates. I just wanted to let you know we're using a the Fitzpatrick skin tone scale for self-identification. So I'd like you to take a little bit of a look and identify what you, or tell us what you'd identify as. So this was an aha moment for me as I thought about my family. So I would say I'm a type 2, my son is a 3, my niece is a 5, and her father is a 6. So from marking Caucasian, my son and I, we are different numbers. My niece and her father are both Black, and they are of different skin tones. Does that make a difference in their experience if they get an IV? So what are we asking from you guys? This wasn't just about the CEs. We have to improve. So we know that we have way too much lack of progress in here. And we also have many, many tools and technology that could combat this. So we can't continue with peculiar indifference. It's been 124, 125 years later. I think it's time. So our ask is we want you to help us by sharing our surveys, by joining our movement, and to end peculiar indifference. So one last.
Just learn how to get stuff done. And what I mean by that is, I've seen at every level, people who are very good at describing problems, people who are very sophisticated in explaining why something went wrong or why something can't get fixed. But what I'm always looking for is, no matter how small the problem or how big it is, somebody who says, let me take care of that.
We want you to be that somebody that takes care of that with us. So with that, we absolutely want to thank you for your time. And we're asking you to take our survey, to share our survey, to ask your family and friends to take our survey. You can use your phone and just scan the QR code, or go to our website that's listed on this page and learn more about what we're trying to do. And hopefully we can make a change and do better in healthcare and get rid of peculiar indifference. Finally, thank you.